action potential inverts the presynaptic potential, as we described. There is a depolarization of presynaptic terminal, and it causes voltage gated channel, and calcium is essentially important. Um, the calcium permeability leads to the influx of calcium channel, and that influx leads to the uh, the um, transmitter molecule release to the cell wall, and transmitter is released into the synaptic space, and for a certain period of time this transmitter release and causes the effects onto um, post synaptic channel. So the transmitter binds to the receptor molecules on the post synaptic neuron, opening or closing of post synaptic channel, and then clearance of these neurotransmitters to when the function is achieved, the movement or transmission and whatever is achieved. So in cases of tetanus, there is a sustained release, or in other diseases like the myasthenia gravis, the neurotransmitter release mechanism fails, so the activity won't happen in those situations. And the end effect is either the muscle contraction or whatever activity, motor activity at the is executed through this electrical and chemical interactions. Okay, if you have any question so far, you can raise your question here before we go further. Any question? So this is how we describe the neurons. Okay, so in this slide you are seeing the glial or supporting cells. The astrocytes looks like that, oligodendrocytes, microglial cells. These are the part of the nervous system, and they are not the neurons, but they are the supporting glial tissue. The importance of this tissue is they have a favorite side of neoplastic activity, because these astrocytes, they are supportive. There is a dynamic activity. They are also the like white blood cells of the brain. These oligodendrocytes, they are also the protectors, scavengers, the nutritional component, the protective component. All these functions are there. So at times, the uh, neoplastic transformation of these glial cells is one of the leading cause of cancerous presentation. We call them as glioma, and depending on the activity of those glial cells, we grade them as a low grade or high grade glioma. The worst form of the glial tumor is glioblastoma multiforme or gliosarcomas. So this is one of the very important clinical area which we wanted to mention. So now in this slide, at one side you are seeing brain after the craniotomy with electrical activation, and the different numbers are intraoperative invasive brain mapping. And on the left side you see an axial and a sagittal image of MRI of brain, and you see the left-sided insular, the blackish tumor. The thalamus is slightly pushed on the left side. This is the left side, this is the right hemisphere. And now, with the help of invasive or non-invasive ways, we can map out the different uh, fiber tracks, the white matter tracks, which are the axons. And this is how we can have an idea of where the brain is, where the important part of the brain is. In here, the speech, some speech area components are pushed laterally by the presence of this insular tumor. And this is the way how we anticipate the pathology or the part of brain with the interconnections, and how the pathology disturbs those, right? So this is the another fiber tracking system, and the biopsy, the cadaveric specimen, the white matter dissection material showing the corpus callosum, the commissural fibers. We also see the associated U fibers between the parts of the frontal brain, the small associated fibers. As we recall that they connects the one part of the gyrus, or one part of the hemisphere, and within the hemisphere there are many association fibers. The small U fibers is an example. The commissural fibers are the corpus callosum, anterior commissure, posterior commissure. Here we also see the perithalamic areas, the brainstem areas, and this is the mid-sagittal section. So this is again the functional brain MRI. Now, just quickly, so there is a cerebrospinal fluid. So that cerebrospinal fluid is mainly secreted by the choroid plexus, mainly present in the ventricular system, lateral ventricle, and some third ventricular, fourth ventricular area also have ependymal cells. So ependymal cells is choroid plexus cells secretes the cerebrospinal fluid in a constant. So these ventricular system are the cavities of the brain, and the cerebrospinal fluid, it circulates within the ventricular system. Here you see the lateral ventricle, the different parts of the lateral ventricle in a C-shaped form, the trigone, the temporal or inferior horn, the occipital horn, and from the foramen of Monro of the two hemispheric lateral ventricles, the two foramen of Monro transmits that fluid to third ventricle, and then third ventricle from the third ventricle with the help of aqueduct of Sylvius, you see that CSF into the fourth ventricle, and from the fourth ventricle, in the floor of the fourth ventricle, there is a midline foramen of Magendie and the lateral foramen of Luschka. This CSF comes out of the ventricular system. It floats down in the subarachnoid space, covering all the spinal column, spinal cord, and it flows back through the arachnoid spaces back into the venous system. This is how the CSF circulation is. And in a given time, there is some secretion of CSF. In a given time, almost 300 250 to 300 ml CSF is present. The normal pressure is 5 to 15 millimeter of mercury in normal physiological conditions, right? So now comes that what is blood-brain barrier. So we saw that how the axons make the building of the nervous system, the different parts, and we also know that there are venous and arterial blood, but the blood does not flow inside this CSF directly. There is a special protective mechanism that the toxic things in the blood cannot reach to the part of the brain responsible for responsible for very sensitive activities, our consciousness, and the nature has provided us this different sort of barrier, which we call as BBB, blood-brain barrier. It protects the central nervous system from toxins and the pathogens. So the CSF, as we know, that it is completely sterile fluid. It has no organism inside. It doesn't have the RBCs in physiological conditions. If there is no infection, the WBCs cannot cross the neutrophils, lymphocytes. They cannot cross the blood-brain barrier in normal conditions. So the recent breakthrough in material science and nanotechnology provides a library of advanced materials with customized structures and properties, serving as a powerful toolkit for the targeted drug delivery. So playing with the characteristics of the blood-brain barrier, you can selectively control the medications, penetrance of the medications. So there are very few antibiotics or medications which can cross through it. So in chemotherapeutic conditions, at times you have to um, puncture in the subarachnoid space to deliver those drugs in different forms. So that's the blood-brain barrier. And here you see the different schematic diagram of the blood-brain barrier, which present um, between the brain parenchyma and the small unbound lipophilic agents can cross. So anything which is lipophilic can cross theoretically the blood-brain barrier. So um, if we see the cross-section of the blood vessels, if we see the endothelial cells, we see the part of the subarachnoid space where the blood is flowing. We see that the blood vessel is surrounded by the astrocyte, the supporting cells. Blood vessel has surrounded by the luminal endothelial cells. So there is a component of capillary visible in the center, the basal membrane, the pericytes, and if we see at this level the the pericytes, we see the tight channels, the tight junctions. So they do not permit any blood cells to go inside the brain. This is how we prevent the blood entering into the brain directly in normal conditions. So here comes a component of electrical activity of the brain and the intracranial pressure. So there is a way to describe the intracranial pressure. So there is a Monroe-Kelly doctrine, which says that the brain is inside a closed sac. There is a closed cavity in which there are three components: the brain, the CSF, normal blood vessels. So their presence of these things have a certain normal physiological pressure, which is 5 to 15 millimeter of mercury or centimeter of water. So whenever there is a new thing like hemorrhage, the space occupying lesion, that can lead to the increase in the pressure. So according to the Monroe-Kelly doctrine, any increase or any additional new thing like hematoma or brain edema or neoplastic activity initially does manifest as compensation by the other component. So here you see the brain is squeezing in to accommodate this fluid, but there is a limit. So this when this limit cross, the intracranial pressure has a in normality has a some wave-like pattern recorded recorded on intracranial pressure monitoring. It if you recall your cardiac cycle, you see that between the different phases of cardiac cycle, the systolic, the diastolic, there are also perfusion of the brain and the return of the blood in the venous system through the venous sinuses back to the right heart using the internal um, jugular veins and the right atrium back to the left side where it pumps back to the circulation. So the Valsalva maneuvers, the coughing, straining, that can leads to the sudden transient changes in the intracranial pressure. But brain is very competent. The autonomic nervous system, the autonomic regulation system, sorry, autonomic regulation system is competent to handle that. But in pathologies, when intracranial pressure exceeds, then this is the magic number 22 millimeter of mercury. There is no more space to be accommodated. There is decompensation, and then the different compartments like the supratentorial and infratentorial compartments.
Uh,
That sorry.
may I excuse you, please? We are running out of time. We can switch to the other link.
Okay, sure.
Where is it?
Uh,
The new link?
In the chat box.
yes.
Ah, yeah, okay, thank you.
Okay, is everybody moving to the next? Should I continue till?
It's about to be end, so I think we can switch
Mhm.
to other link.
Sure. I'm in the waiting.
Yeah. Can we please switch to other link? Yes.
And
Yes.
Problem in intracranial pressure, right? So this is what the intracranial pressure curve is, and there are intracranial pressure curve shifting in chronic conditions. So here you see the three major factors regulate the cerebral blood flow. So this is cerebral perfusion pressure. As we said that this normal condition, there is a certain straight horizontal line where the cerebral perfusion pressure is maintained in a normal range, irrespective of the changes in the blood pressures, mean arterial blood pressures. Okay. this cerebral perfusion pressure shifts, the curve shifts in different conditions. Like if we see the green graph, let's first see the reddish one. The factors regulates the cerebral blood flow under physiology. Carbon dioxide is a major factor which can lead to the shifting and temporary compensations of these graph numbers and graph stability. So this is how the cerebral autoregulation happens. So in the blue, we see that the patients with hypertension have their autoregulatory curve shifted to the higher reading sides, just like this. And in severe hypoxia, the curve gets disturbed. So we are not going into that details. Right? So we stop here from my side. So this is the brainstem, vasomotor and circulatory centers are present in the medulla, and they are important in the autonomic connections, auto-regulation systems, and they keep the cerebral perfusion pressure maintained by different cardiovascular sympathetic autonomic system changes the carbon dioxide breathing centers coordination to keep this cerebral perfusion pressure the maintained to a normal level for normal functionality of the brain. I think we stop here.
Thank you, Dr. Ratta, for envisioning us with such a nice presentation. And Moriba wanted to ask something. Moriba, if you are here, you can ask, please. Anybody else want to ask something? Please.
No question, no comments, no. So in that case, we can start asking things. We presume that everybody has understood everything. So now let's just.
That's a good idea.
I think the whole idea is just to encourage you speak out with the. I mentioned it right from the start that this is the most important stage where you could interact, and if you take the active participation, we will understand and we try to improve our quality of delivering these concepts. Otherwise, we will not understand where we need improvement or where you need us to explain further or follow a different strategy. So even if you don't want to speak, you can drop in the chat box.
So, Francesca Migani, Theo, please go ahead.
Good evening, Doctor. Thank you for this enriching presentation. I have a question concerning the monitoring of intracranial pressure in the ICU. I wish to really understand how do we interpret the results of the intracranial pressure monitoring and what are the implications for patient care? I want to say that it's something that I've never known. Throughout my internships, I've never seen the different types of intracranial pressure monitoring devices. So please, if you can enlighten me concerning that question, I'll really appreciate. Thank you.
It's an important question. If you see this slide, no? Okay, let me
No,
just.
doctor.
Let me see if I could share my slide, so I could. Okay. You see my slide? Not yet.
Yeah, okay.
Okay.
Yes, doctor.
So I'm not going into the detail of the companies making different type of ICP monitor. We are just here to discuss the concept. So this in many lower middle income countries, since this system is expensive, the handling of human healthcare workers, the training, the presence, that is not there. So many times we don't see it in our ICUs, and that is the main flaw in our neuro ICU ICU setups. So that is a limitation for neurosurgeons. So you see that the intracranial pressure monitoring system has a ventricular catheter, the pressure transducers, the manometer, and the drainage bag. These are different components. So the structure could be different. The material can be less expensive, more expensive. And this is the monitor. Just like if you are aware of central venous pressure, CVP monitoring, that is routinely done everywhere almost. Have you seen CVP monitoring? The monitor shows the CVP as the invasive arterial blood pressure. The similar type of transducer is placed inside the blood vessel. And the monitor shows that the blood pressure is going, say, in the invasive ICUs, the blood pressure fluctuations are seen in real time. Have you ever seen CVP monitoring system in neuro ICU with this sort of monitor provided by different companies? So the monitors has an option of like pulse, blood pressure. There is also CVP, ICP monitor. So that component is also, you see multiple functions are being seen on monitor in real time. So this catheter is placed either inside the ventricle or inside the brain through a operation, which can be done on the bedside in emergency room or inside the operation room. So this transducer is tunneled under the scalp, and the part of that catheter comes out. It is connected with the pressure transducer connected to that machine, and the other side is on the manometer and drainage bag. So you keep this because we know that the 5 to 15 centimeter of water is the normal pressure. So I told you that the maximum production of CSF is at the level of foramen of Monro in the lateral ventricles. So we keep that level of drainage bag according to the level of drainage. So if we want to encourage the CSF drainage, we keep it little lower down, or if we don't want CSF to be drained out, we keep it at the higher level. But we keep monitoring this. Suppose in traumatic brain injury, in a brain edema, if we are seeing a patient with comatose, we can not assess based on the Glasgow Coma Scale, which is already low. Patient is anesthetized, patient is on ventilator, sedation relaxations is being given. So this ICP monitor change, the number of ICP, if it becomes critically more than 20 to 22, we may decide for doing a surgery in the form of decompressive craniotomy when we remove the brain um, the part of the bone which is called as the decompressive craniotomy. So we remove it, we keep it in stored inside the body or in the refrigerator to be placed when the ICP and brain gets relaxed after a few weeks time. So this is very critical to assess in a comatose patient, in a ventilated patient. So the cost of this, the system is high, so we don't see it. The cost of whole system, the cost of the monitoring capabilities and sophisticated ICU. That's the difference between a level 1 major neuro ICU and in the ICU where we don't see these things. I hope you got that.
Thank you, Doctor. I have a second question, if I can continue.
Mm-hmm. Sure. Are you a neurosurgery resident or neuro ICU resident? Do you want to share that?
Doctor, I'm a junior medical student.
Oh, okay. So you have done rotations in neuro ICU.
Yes, Doctor.
Mm-hmm. Which country are you from?
I'm from Cameroon, Doctor.
Okay, good. Go ahead. You can ask second thing.
Okay, Doctor. We said earlier that during patient management, when we have an ICP of 22 millimeters, we should take
centimeters.
22. Yes, Doctor. We should immediately intervene in the patient's care. But I want to ask, is it the same limitations in non-hypertensive patients, the ICP?
I'm just giving an example that the cutoff raise in ICP may lead to the change in strategy of treatment. So usually the 22 is a high number based on the different large scale studies in traumatic brain injuries and other raised ICP, that the herniation is highly likely after that number. So depending on that, you take the decision of yes, as you mentioned, that the blood pressure has a role in ICP. There are different type of medical therapies to relieve that edema. To by taking out the CSF drainage, you can give the ICP a chance to get decreased in pressure, or you can use hypertonic solutions. In previous days, mannitol was routinely used, but now 3% the hypertonic fluids are injected for reducing the pressure. The ventilated patient, if you wash out the carbon dioxide, the hyperventilation, the increased rate of ventilator can lead to some decrease in the pressure, the ICP. So you do all sort of, even a patient who is lying and has a kinked in uh, neck structures can lead to decrease venous pressure. That venous pressure decrease can lead to increased ICP. So if you elevate the bed, you keep the head neutral, it encourages the venous return, and that is also one way to reduce the pressure. When everything conservatively fails, you have an option to go surgically and do the um, um, either you deal with the pathology, like if the brain hemorrhage is causing some problem, you remove that in extradural hematoma or subdural hematoma. At times you remove the bone above that hemisphere, we call decompressive craniotomy. So this is how we try to surgically control those cases where the medical therapies failed. So I told you the position of patient, the venous return, the hypertonic solutions, control of blood pressures. That all is the first line of management of ICP. If it fails, then the invasive things can be done. So ICP monitor is a blood pressure monitoring. So if you know the number, you know the fluctuations, you see the response, you based on that you can change your strategy of treatment. Okay.
Thank you, Dr. Atta.
Thank you, doctor.
Anyone else have a question? May ask. Or if no one has any question, then we can end the session, Dr. Atta and Dr. Bang. Or you want to say something?
Dr. Ban, from my side, we can.
From my side as well, I would just like to add some short thing personally that
Thank you, Mr.
not happy with the situation that I haven't been here for the last meetings. I have had an issue with traveling. The rental car was broken. I have lost my phone, everything. My cards have been stolen. So I'm working me back to normal life. This is just the short thing I wanted to mention.
Thank you, Godfrey.
Thank you, Dr. Ban. You manage it.
Yeah, thank you, Dr. Ban. Thank you, Dr. Atta.
Okay.
Thanks for your time.
Thank you, Halim, and all the participants.
Thank you.
So somehow the number in these two lectures got decreased, and we don't see many known names. So but we are happy that the people are interested, and we have a reasonable participation.
Thank you very much. Thank you.
But we would like you to request to actively participate and engage in, so we know how to fulfill the gaps. Okay.
Okay.
Thank you. Thank
So,
you.
thank you, everyone.
Thank you.
We are gonna sign off. Take care.
Thank you.
Thank you.
Thank you, Jane. Thank you, Elvin. And all. Stay blessed and all the best.
Thank you.
Okay. Bye.